Good evening. Warm welcome to the 47th webinar of Pediatric Orthopaedic Society of India. The topic of today's webinar is fibular deficiency. And I'm sure that this is one of the most challenging and the complex problem of pediatric orthopedic. And we are really fortunate to have experts with us. We have James Fernandes from UK. We have Professor Gamal Hosny from Egypt. We have our own Milind Chaudhary from Akola, India, and Kovoor from Kochi, India. Before we go to the actual lecture part, let me introduce our faculty. Professor James Fernandes is consultant at Sheffield Children's Hospital. He has a vast interest in limb reconstruction, developmental dysplasia of the hip, and skeletal dysplasia. He was a president of British Limb Reconstructive Surgery, secretary of British Society of Children's Orthopaedic Surgery, the past president of Assami of Britain, and again International Limb Lengthening and Reconstructive Surgery Society. In addition to orthopedics, he has a keen interest in ancient history, traveling, and I must congratulate him and appreciate his philanthropic activity because every year he visits India and carry out surgery as well as the examination of a complex cases. I introduce and welcome Professor Gamal Hosny from Egypt to the POSI platform. He is coming to our platform for the first time. So welcome, Professor Hosny.
Thank you.
Yeah, he's a consultant and head of the department at Behna University Hospital in Egypt, Cairo. He's an editor of Journal of Pediatric Orthopedic B. In addition, he was past president and the current president of Egyptian Orthopaedic Society and Assami International. Milind Chaudhary does not need any introduction, but for those who are new to the deformity correction and the young orthopedic surgeons, he is the director of Center for Ilizaro Technique in Akola, Maharashtra. He is a chief editor of Journal of Limb Lengthening and Reconstructive Surgery, the past president of Assami, India. He is the recipient of Service Above the Self Award by the Rotary International. And in addition to orthopedics, he plays tennis on a clay court, which is a 140-year-old clay court in Akola, and does bird photography. Kovoor, the young and the dynamic deformity correction surgeon of India. He is a consultant at Ernakulam Medical Center and Esther Medicity in Kochi. He is a past president of Kerala Orthopaedic Association. And beyond orthopedics, he has a keen interest in traveling. A few words about the format of this webinar. In the first half, we will have lectures, the short lectures of 8 to 10 minutes. The first lecture will be on the topic whether one should go for a reconstruction or an ablation. That will be by Dr. James Fernandes. Then Professor Hosny will speak about the management of ankle deformity in Fibular Hemimelia. Then Dr. Chaudhary will speak about the issues related to lengthening of tibia in this condition. And then last, Dr. Kovoor will speak on a very unusual problem, that's a clubfoot in the management of fibular hemimelia. After that, we will take audience question and the questions by the faculty. And then according to the time which is remaining, we will go for the case discussion. If you have question, please, I'm sure that everyone will have one or the other question. Please send your question to Dr. Hitesh Shah on 90362 51570. If you want, you can take a snapshot of this so that you can ask question at any point. At the end, I would like to tell about the upcoming webinar. On the 6th of December, after 10 days from today, we have a webinar on, again, a very challenging problem, radial dysplasia. And we are fortunate to have expert of the topic, Maribeth Izaki from USA, Paul Smith from UK, Scott Kozin, again from USA, and Rujuta Mehta, not USA, but from Mumbai, India. So with that, I hand over to Professor James Fernandes for his first talk. Over to you, James.
Thank you.
At the outset, I'm very thankful for this invitation to Dr. Ganjwala, and I think it's a good topic to be with good faculty on this issue of fibular deficiency. My remit is that about classifications as well as a little debate about whether to reconstruct or to ablate. I have to thank my fellow who's also helped me in this presentation. For those who are still in training, fibular hemimelia is a spectrum of a longitudinal deficiency, which is post-axial. In a simple term, one might think it's just a short fibula to complete absence, but actually the reflection is of the tibia, because the tibia is the one which is too short. But one should not forget that it comes with associated anomalies. Quite often there'll be some amount of femoral deficiency, retroversion at the hip. There could be acetabular dysplasia, genuvalgum at the knee, and the classic hyperplastic.
James, kindly share your screen.
Can you hear me?
So, yeah, we can hear the PPT. You can share the screen.
I have shared it, I thought. Sorry. It's not clear. Okay, sorry. Has it come through?
Yes.
Oh, I apologize. Shall I go back? I'll be quick.
Yes. Yes.
Yeah. For those who are in training, fibular hemimelia is a post-axial longitudinal deficiency, though the term is a short fibula, which is true, but actually affects the whole leg compartment, which means the tibia is also significantly involved. There are associated anomalies of the femur, such as femoral deficiency, retroversion at the hip, and dysplasia. At the knee, genuvalgum or hyperplastic lateral femoral condyle, and a variety of cruciate deficiencies. I'll show you a classic picture here. As you can see, the anteromedial tibial bowing with a skin dimple, and also the most important part of all is the ankle and foot with missing raised ball and socket and tarsal coalitions. Regards to classifications, based on all these components, which I've already mentioned, which are on the left-hand side, there are quite a few classifications which are put there on the right-hand side for you, and we'll go through each one of them. Now, this was published in 1952, Coventry and Johnson, and I suppose they're not greatly helpful, especially for treatment. It's just a little descriptive classification. Similarly, when I first started doing orthopedics, I used to use this classification for fibular hemimelia, and this also is quite descriptive depending on the appearance of the fibula. Stanitsky and Stanitsky's paper published in JPO 2003 was an interesting classification. Probably the best part I liked was about the ankle and the shape of the ankle. I think to some extent you can design operations to that, and similarly to the subtalar joint. But Birch published his classification in 2011, and this is what I feel is quite easily help you in decision making in your clinic, and it's very simple, straightforward. It's all about the foot, the terminal end organ. If there are 3 or more rays, it produces a stable weight-bearing platform, and then based on the length discrepancy, which you can see on each of these type 1A to type 1D, then you can decide. Hello? Can decide whether it needs just a contralateral epiphysiodesis based on protection, or you need an epiphysiodesis with lengthening, or 1 or 2 lengthenings or epiphysiodesis, and if it is severe, more than that. Now you should remember, if the foot has got no or less than 3 rays and is not functional, and you have to be careful whether the upper extremities have got birth defects or not. If the upper extremity is normal, then of course it's possible for you to go do either reconstruction or ablation. But remember, if there are no upper limbs, we want those children to use their feet, like many of the conditions where we want them to become to use their feet and mouth. So they are not for amputation. Paley has classified predominantly about the ankle, and based on that, he has an algorithm for surgery. Mainly, it's again clinical based, but of course here it's very schematic with diagrams and so on. I think it will be discussed later on based on that. Everyone forgets about the knee, and cruciate deficiency is quite often associated. We also looked at it and published this in the Journal of Limb Lengthening and Reconstruction Surgery. This is just a classification if anyone wants to know, from Manner et al. So what are the issues with all this classification? One thing I feel is none of these children come with an isolated fibular hemimelia. So these classifications do not address combined deficiencies. So either it's combined femoral and fibular, but everyone also forgets the height below the malleolus. The good thing about Birch's classification is it considers upper extremity function, and I think it's quite important. Some do not address ablation, such as Paley's classification. There's nothing much mentioned about bilateral deficiencies. So one has to individualize your treatment depending on the presentation. And of course, all this classification do not address social, societal, or cultural differences. And this makes a big difference. United Kingdom is a welfare state, and we also have to think about costs. Similarly, in lemic countries, one has to think whether the acceptance for ablation is there in severe deficiencies. So what are treatment goals for any limb reconstruction surgeon for limb length equalization is to have stable joints with reasonable range of motion at the end of your treatment when they become adults, a reasonable axis, almost equal leg lengths. But to achieve this, I basically think very carefully about doing everything with the least psychological trauma, with no compromise in educational progress of the child or the rest of the family. And therefore, you have to take in many factors in your decision making. So two options here, either biological reconstruction, where it includes the foot and ankle reconstruction and limb length equalization, versus I've chosen the word ablative prosthetic reconstruction. It is still called reconstruction because you're just making them still ambulate from point A to point B with a prosthesis, but a single operation. So you can, my favorite surgery is a Symes disarticulation. You can choose other modifications such as Boyd or Pirogov. To me, the foot actually determines a lot of my decision making, and therefore Birch's classification comes into this significantly. One has to think about coalitions to see whether the foot is supple or rigid, and you might have to design further operations, like how Paley has published on it. And therefore, if there are 3 or more rays, I would err on reconstruction, which being the main determinant. Other deformities at the ankle or coalition, they do not dictate much in between reconstruction versus amputation. Also, the next thing is limb length difference and the ability for you to predict. And I suppose up to 10 centimeters, it yields very good predictable results. Recent studies, people are pushing the boundaries with better techniques, physiotherapy. But one thing is, if you choose your patients correctly, you should possibly avoid ablation after all your efforts in the first few years of this child's life. So this can cause significant psychological trauma. And of course, with old techniques and new techniques, you can stage them accordingly. And we rarely go for one single large lengthening, partly because we don't have the same physiotherapy backup as maybe in the United States or in Kurgan. You can achieve them initially with fixators or lengthening nails, and try to do them in interval periods. I usually do them in non-school important years so that the children don't suffer with their education, which is also important. If I want to go for long lengthenings, I would do staged, one focal point at a time rather than 2 at the same time, and protect the foot throughout the lengthening. Just to go through some papers, this paper, which was Birch and Paley's, both units, they collected and did a study based on psychosocial quality of life and so on, including a time 25 to 50 yard dash. At age 9, they did not find any much differences, as well as both the groups were satisfied. Whereas the long term at 33 years average, this paper from Janet Walker, John Davids as a senior author, they looked at and they found no differences in majority of those things such as education, employment, income, even looks of the appearance and so on. And no patient, either group had depression. But one thing was very important was the quality of life was that job satisfies content scale was better in amputees. And this recent meta-analysis by Herzenberg's unit, JPO 20, 7 retrospective cohort studies, and they felt that amputation surgery probably produced better satisfaction, and reconstructive surgery had higher surgical complications and very problematic unresolved foot and ankle deformities. And therefore, some of the recent newer studies, probably because we are becoming better at it, they felt there is no great difference between the two groups. So I still believe in the original old papers that of Johnston, what he said about foot, the number of rays, the ankle, and shortening dictates the final outcome in the milder group, whereas Choi said that ablative surgery is a simple single surgery, mostly satisfactory. For all of us, we should not forget that we all are in different cultures, and ablation may not be an option. Complex reconstruction will have its own problems, including loss of joys of childhood for a child coming to you over those 16 years. And least of all is we will end up ablating. In our original series from Sheffield, of the first 67 fibular hemimelias, 2 went on to have ablation at the end. And I think there were poor patient selection. So again, everything boils down to patient selection. In summary, to some extent, what I've said before, you have to analyze whether there's a combined deficiency, femur and leg component. Again, the number of rays, which will dictate your reconstructive pathway or not. And finally, in terms of amputation, though I favor the sign, you can do other procedures. And reconstructive, there are a lot of newer procedures described, such as the short and the super ankle, and so on. Just to show a quick example, so this little child, 2 lengthenings with an osculsis osteotomy at final at discharge. She had a good result, 3-ray foot. And this is another one. He had 2 lengthenings to start with, 4-ray foot. You can see guided growth, epiphysiodesis on the opposite side, and a final correction, and the ankle had to be fused. He is a civil servant at the moment, doing quite well. Remember, complications are always seen. I've just put a slide to show you ankle subluxation, and this is an important point for all of those who, if you're going to do limb recon surgery, not frequently, but you have to cross your frames to the ankle, across the ankle rather. Ablative, as you can see, this foot, it's not a functional foot, non-functional 2-ray. You can get a nice Symes procedure done. And this is an adult girl with who has been discharged with a final result. The outcomes of Symes have been quite good. Even Birch in 1999 and McCarthy in 2000, they fared very well according to their paper. And therefore, I think limb lengthening needs to be justified both from the point of view of functional, psychological, and cost-effective results. I think the general consensus, at least in the Western world, is lengthenings of 2 or less are cost-effective and functional. And just to tell you a few other publications, I'm not going to go through all of them. Reconstruction in mild to moderate shortening has had good success rates. Severe forms had major complications, as from Birmingham in the UK and Katani. Whereas with amputation, definitely better than reconstruction as per Birch 2011. And the recent paper from Peter Calder, amputation provides good short-term function, even with extension prosthetics for long-term function. At the end of the day, in summary, the decision has to be made by the individual surgeon. I run a combined clinic with the rehab medicine and prosthetists, which makes very easy for the family to make the decision rather than myself. I think for those of you who are in low-income, middle-income countries, amputation may not be a choice, but this might be something you may have to think of because it might be too expensive for the patient to have reconstructive surgery. 2 lengthenings and a contralateral epiphysiodesis is a reasonable reconstructive plan. And like everything else, you have to assess the joints, protect them. Last but not the most important, lastly, is choose the treatment to your setting and your capabilities and expertise. Thank you very much.
Yes, thank you, James, for an excellent covering of all the indications related to ablation as well as lengthening. Before we go to the next lecture, I have a very quick question. You said in 2 patients after reconstructive surgery, you had to go for ablative procedure. So what went wrong in your decision making? Because you must have taken all these factors into consideration before you decided to go for reconstruction. But what ultimately happened so that you had to go for ablative procedure?
Yeah, they were not primarily my patients. They were inherited from, I think I would say, the initial limb reconstruction service when we were doing surgery. Possibly the technology had just arrived from Kurgan or Elizarov, and we were just sort of trying to push the limits. Maybe the choice was wrong. I think that's where it failed. And eventually, when you don't have a good functioning foot and ankle, that was the case. The appearance was not right, and they had pain or they were too stiff. They didn't like their gait. Actually, one of those went on to become a doctor after amputation. So I think those were the reasons rather than anything else. So I'm very careful now how in the decision making, you have to give them literature as well as your own capability of how much you can push your boundaries in reconstruction. I think that's the most important thing. Yeah.
Okay. With that, we go to the next topic, and I request Professor Gamal Hosny to speak on ankle reconstruction in fibular hemimelia.
Thank you so much for the invitation. It's a great honor for me to meet my Indian friends and to meet James also at the same time. I'm going to speak about the ankle in fibular hemimelia. What are the limitations if you want to talk about fibular hemimelia?
Just a minute. Can you go for the full screen mode?
I did. It's full screen mode now.
Okay, not on our side. Fine, please go ahead. Please go ahead.
I can make it again. Just okay.
Not yet, but fine. Please go ahead. Don't worry. We can read very easily.
Okay. We have serious limitations if you want to talk about the ankle in fibular hemimelia. Few number of patients. Most of the papers are based upon few number of patients. The second problem, historically, not even historically, in many centers now, the treatment is amputation. So how can you classify the ankle problems if you do amputation in all the cases? I remember a long time ago, I was a resident with Mike Benson in Oxford, and it takes for me about 1 or 2 minutes to convince the families of the parents of children with fibular hemimelia to have amputation. And it was very simple and very easy. The second, which is the real problem, are the classifications. We have too many classifications. They are based upon patients diagnosed at birth, which is not the case in many situations. Again, animation-based classification. Can you imagine that most of the classifications in congenital deformities are based on animations, not on real patients? It's non-evidence-based medicine. It's a great problem. It's a new trend to have animation-based classification. All what you need is to dream at night with a classification, and you have few technicians. And then you repeat your classification everywhere again and again and again. And it's a new classification. Can you imagine? Let's go to the real world. Now we have the first presentation with 14 years old boy, 19 years old girl, and first presentation at the age 34. Can you imagine? Look to the classifications. Look, this is very simple. Short fibula, vestigial fibula. And this is classification. Totally dislocated ankle. And which classification is this? Which classification? Again, look to these cases and tell me how to classify them. In this case, or that case, or that case. So the simple thing is to do animation, just. You don't have to classify real patients. And look to this patient who's bilateral fibular hemimelia. You have complete absence of the fibula. Yes.
Please. Yeah, we are not like your slides are not progressing. Like it's on the second slide only. We are not able to see the slides after second slide. Can you stop sharing for a minute and then do it again?
Yeah, there is a problem. I'm sure that there is a problem.
Yes, now it's moving.
Now it's moving?
Yes, yeah.
Yes.
Try to move once again, Gamal. Just go back to display whole screen.
This is okay?
Yes, yeah, please.
So animation-based classification is the new trend. And so this is the first presentation of these patients at the age 15, and this patient 19, and this is first presentation at the age 34. Is it clear now that it's moving?
No, it's not moving. It's not moving.
I do not know. Is it moving now or?
No.
No. Yes, now.
I don't know what to do now. Just. Is it clear like this?
Yes, its classification, does it help at this stage? Yes, we can see that.
Yes, you can see that. It's okay.
Yeah.
So see if you classify this patient, does it help? Does it help you to diagnose or treat or anything of any classifications available? No way. You see. And look to this patient. Does classification helps you to treat the patient? No. So what are we going to do? Amputation or reconstruction? The basics in such a case with one ray foot and the severe deformities to do amputation, the so-called conventional. And look to the patient. We treated the patient. Now we see the patient with one ray foot. So it has to be amputated. And look to the ankle here. What type of ankle is this? We don't know. Which classification? We don't know. Look to the ankle. And moving from theory to practice, look to the patient, how the patient walks. Do you see the video now or?
No, it's not moving.
Anyhow, she's moving. The people has to play it. Has to believe me. Just again, the way she walks with normal shoe. What can you see in the ankle in the fibular hemimelia? You can see a short fibula, vestigial fibula, ball and socket ankle, wedge-shaped distal physis, subluxed ankle, dislocated ankle, tarsal coalition, and misshapen talus, shape and direction of the articular surface. You can see any of these problems in the ankle or any combination of these problems. Again, there is a relationship between the genovalgum and ankle deformity. Perhaps genovalgum increases the stress and the valgus moment on the ankle and increases the incidence of recurrence. So the second problem is the unstable ankle. People say that you have an unstable ankle in 92.2% of cases. But what do you mean by unstable ankle? If this is an unstable ankle because they have an oblique joint with a short fibula, or this is unstable ankle because it's dislocated with a strange shaped articular surface, and this is unstable ankle because you have this is small articular surface. Perhaps you have mechanical instability because of anatomic changes that may exist in isolation or in combination. And ankle movements beyond the physiologic limit. We don't know. Anyhow, this is the case of fibular shortening. And we lengthen the foot for 11 centimeters. Lengthen the fibula for 11 centimeters. Look, with 7 years follow-up, look to the ankle joint. Again, ball and socket ankle, ball and socket. Is it a real problem or is it secondary to adaptation to coalition and hindfoot stiffness? Look to the ball and socket ankle. What about vestigial fibula? This is the vestigial fibula here. See, very small fibula, far away from the ankle, small segment. She's one of the residents now, this case. And we did corticotomy of the femur and tibia, and we isolated the fibula with a ring, and we do differential distraction of the fibula. Down. During lengthening of the femur and tibia and the correction of the deformity, there is gradual descent of the vestigial fibula, as you see here. And this is the end picture. This was the site of the fibula, the vestibular fibula, and this is at the end of the treatment with ball and socket joint. She's one of the residents now. This is after 8 years follow-up. What about if you have a dislocated ankle, abnormal articular surface? I don't know which type of classification you are going to use. You see this is dislocated ankle. We did gradual distraction of the calcaneus. And you see here, then during removal, we put multiple wires from the heel to correct the deformity. And this is the end picture of this ankle. Again, you have a dislocated ankle with a short fibula and oblique. We do distraction first to correct the dislocation. Then osteotomy of the fibula and the gradual descent of the fibula. Arthrodesis is a good solution sometimes. Unfortunately, with cases having arthrodesis in the young age, we have progressive ankle deformity, progressive valgus ankle deformity after arthrodesis. Look here, progressive. So we did supramalleolar osteotomy and also did 2 other osteotomies. One here and one at the level of the arthrodesed knee also. And 1, 2, and 3. So we have 3 osteotomies. And we corrected the deformities gradually and lengthening. So this is trifocal lengthening. Look to the ankle. In conclusion, the current classifications try to simplify the ankle deformities. However, there are wide variations, wide varieties of anatomical abnormalities which need detailed analysis before treating the patient. Don't think about the classifications because they are of no help in treating patients at all. It's better to analyze the deformity for each patient. Remember that the current trends or the new trend are the animation-based classifications. So people talk about the evidence-based medicine everywhere in internal fixation or something. But limb reconstruction, we talk about animation-based classification. Can you imagine in the 20th century? The ankle in Fibular Hemimelia, in conclusion, you can have short fibula, vestigial fibula, ball and socket ankle, wedge-shaped distal physis, subluxed ankle, dislocated ankle, tarsal coalition, misshapen talus, shape and direction of the articular surface, strange or abnormal shape and direction of articular surface. Remember that these ankle problems can be treated concomitantly with limb lengthening in some cases. You don't have to treat them first, then you do lengthening afterwards. You can treat both at the same time. Thank you.
Excellent presentation, Professor Hosny, and a very new idea about the management of ankle in fibular hemimelia. You rightly said that usually after ankle reconstruction or along with the reconstruction, we need lengthening. And for that, now let's hear Dr. Milind Chaudhary on his views about how to carry out lengthening, what are the challenges and what are the difficulties of lengthening in this condition. Yeah, Milind, please. Milind, we can't hear you.
We can't hear you.
Muted.
You're muted, that's right.
Not yet.
Milind, your slides are fine, but we can't hear you.
No, not yet. Can you check your mic? Not yet. Now, Milind, what I suggest is that because we can't hear you, we stop at this point and we take the next presentation. By that, if you can change your laptop or your computer, that would be nice. Yeah, Cherry, can you go
Yes,
for
sir.
your presentation? Yeah.
Yeah, will do, sir. One minute, sir. Okay, sorry for the thing. Can everybody see my screen?
Yes, please.
Can you hear me also?
Yes.
Okay, my topic is on clubfoot and fibular hemimelia. Thank the organizers for giving me this talk. Greetings from my town, Kochi. So, foot and ankle deformities in fibular hemimelia, we have distal tibial valgus and procubatum, ball and socket ankle joint. The ankle joint can be stable with no deformity, unstable with valgus, equinovalgus, that's the most common, occasionally varus. Similarly, subtalar joint can be sort of normal, coalition with equinovalgus and coalition with equinovarus, which is rare. Midfoot also, calcaneocuboid coalition, talonavicular coalition, absent lateral raise, bracket first empty, first metatarsal, syndactyly. A lot of combinations and permutations can occur with fibular hemimelia. Now, regarding clubfoot deformities in fibular hemimelia, it's not a very common deformity, and the largest series is by Paul Kasky from Shriners Hospital in Washington. They, over a period of 70 years, identified 147, out of 147 cases, they identified 23 clubfoot cases in fibular hemimelia. That's about 15%. And most of them were Kalmachi's classification type 1A, the 15 cases. And others also were, other types of fibula hemimelia also had club feet. Now we had about, over a period of 17 years, we had 30 patients, 32 limbs. And we had 9 fibula hemimelia syndrome and 23 the usual fibula hemimelia. And our foot deformities were equinovalgus. Equinus was more common. Equinovalgus, plantigrade foot, planovalgus. Ipsilateral club foot, we had about 4 cases, that's about 13%. And interestingly, we had contralateral club foot, which I'll come to in the last, towards the end. Now, in the club foot, 3 of our 4 cases were in the fibula hemimelia syndrome. 1 was in the usual fibula hemimelia. This is a 1-month-old child with fibula hemimelia and club foot, treated elsewhere by postromedial release. Some of the child had a plantigrade foot, but I've not seen the child for a long time. This is an interesting case. A 7-year-old boy operated previously for club foot by postromedial release and a tibialis anterior transfer. There was no correction. So this is the initial X-ray. Other than the 4 rays, nothing else is seen. This is on presentation to us. Now, he had 4 centimeter shortening when we saw him, and the tarsal subtalar coalition, talocalcaneal coalition, which was in varus, and forefoot adduction. So we have a problem, varus and equinus foot and shortening. So for the varus foot, we corrected the hind foot with lateral based bed from talocalcaneal coalition and metatarsal osteotomy for the forefoot correction. But the equinus, in spite of the release, we could not do it. So anyway, there was shortening. So we did equinus correction along with lengthening with the Illicero apparatus. The equinus got corrected and also lengthening also was done. And that's the lengthening, and that's the end result, plantigrade foot and correction. Now, my advice to the junior colleagues is whenever you see a club, any foot deformity, check the number of toes. If the number of toes are deficient or not normal, check for shortening and then keep in mind tarsal coalition. You may need an MRI. Now, this is another case, a 1 year, 3 months old boy, son of a physician, previously treated by Ponseti method by another doctor, another orthopedic surgeon. The father noticed that he somehow diagnosed rocker bottom foot. Basically, it was not going into full dorsiflexion. And this is the foot. Now, I also really didn't notice things. Only in retrospect, I noticed. Now, if you notice, the 3rd toe is overriding the 4th toe. Other than that, there's a subtle shortening, which on careful examination only you would see. The only reason why I diagnosed, detected the fibula hemimelia is I take an X-ray for all relapsed club foot cases. And when we took the X-ray, there were only 4 metatarsals in spite of 5 toes. And of course, the tendoachilles was tight. We deformity fully corrected with tendoachilles lengthening. Now, this is another 21-day-old female, club foot with fibula hemimelia. We started on serial casting because I didn't want to do anything else. Probably we hope to have achieved some correction with that. So my take is with club foot with fibula hemimelia presenting early, it's difficult to determine the status of subtalar joint and ankle joint in the neonatal period. I would recommend start with serial casting. If correcting, tenotomy of the tendoachilles. If not correcting, MRI to rule out talocalcaneal coalition. Now, a couple of cases, 2 cases we had fibula hemimelia with contralateral club foot, and they behaved like normal idiopathic club foot, treated with Ponseti method and full correction. The only difference was instead of the ankle for the foot angle, the Dennis Brown splint, we used the molded AFO, and we could maintain the correction. This is one of the patients, young baby girl, contralateral club foot with normal, corrected by Ponseti method, and the fibula hemimelia deformity corrected and lengthened, and that's the end result. So I'll stop here, sir, because the next one is a case presentation. That we'll do it if you have time.
Yes, absolutely right. Thank you, you, Cherry. Milind, would you like to try once again with the...
Yes, can you hear me now?
Oh, yeah.
Yes, absolutely
Great.
perfect.
Lovely.
Yes, good.
All right. So let's see. Great. Thank you very much, Professor Dhiren Ganjwala, POSI, for having me on this very interesting topic. I would like to begin by saying that my brief today is to speak on the role of limb lengthening in fibular hemimelia. I must point out that over the years, what we have discovered is that fibular hemimelia is our understanding of the disease and the way we learn to tackle the different problems that we face are a work in progress. And definitely, since I have been doing this for the last 30 years, I discovered how much we have yet to learn and how we have gone along and improved and improvised in the best possible manner in which we can help the patients who present with this condition. So while the major issues with fibular hemimelia relate to the shortening, the fibular deficiency at the ankle, which may be a slight proximal migration of the distal fibula, or a ball and socket ankle, or a valgoid deformity at the ankle, or we will have the hindfoot deformity consisting of the talocalcaneal malfusion or malposition. That's in which the calcaneum frequently lies lateral to the talus rather than lying underneath it. And then, of course, the procarvatum and valgus, which is rather obvious. And what's not obvious is the anterior cruciate ligament deficiency. So I would like to briefly highlight, a few salient experiences with limb lengthening, of which I have considerable experience. So this is a young lad who comes to us with some shortening. This is a scanogram which we take. And for the sake of my younger colleagues, I must point out that this is what is known as an orthoröntgenogram in the center, which is a scanogram. They mistakenly people call the full-length X-ray as a scanogram. A full-length X-ray is a long-leg film, is a teleoröntgenogram. I'm sorry about the sermonizing, but let's get the nomenclature right. So here he is with about 5 centimeters of shortening at the age of 5 years, and this is how his hindfoot looks with the hindfoot malposition. So we chose to perform a deformity correction of the foot with the Elizarov apparatus. We have considerable experience in the accurate translation of the Ponseti maneuvers with the Elizarov fixator. So we could supinate and abduct the forefoot and then correct his hindfoot deformity within the Elizarov frame, coupled with a limb lengthening. And I would like to reassure my colleagues and young friends that the Elizarov can be very comfortable for the young children if you do it right, because the frame is really strong and stable compared to the weight of the child. They can really move about very happily without too much trouble, given a little encouragement and enthusiasm on part of the surgeon. So here he is at the end of the treatment with pretty good function. And we have also performed realignment of the hindfoot. The calcaneus has come down significantly and the equinus has been corrected. And we will be following up this child. Note that the lower level of the fibula is at station. Here is a young lad who came to me more than 20 years ago with a rather significant deformity and shortening. The grandparents especially were very, very disturbed with the state of affairs. So in the very beginning, we performed the realignment of the hindfoot by performing an open wedge osteotomy to correct the procurvatum that's present in the lower tibia, as well as the valgus that's present, by opening the wedge laterally and posteriorly. And I resected the fibular anlagen and used the fibrous anlagen to fill up the gap within the tibia, which healed up rather well. Now, at that point in time, I did not learn that, that I could shorten the tibia and use that to fill up this gap, which we have learned over the years. As I said, this is a work in progress. So here he was in the second stage. We actually shortened and resected him in the middle to correct the procurvatum and valgus deformity. and then use the Taylor spatial frame. This is 2005. I've been using the TSF since 2002 to lengthen. You can see that the distal ring is far below the foot, and there is an outrigger to help him walk on it. And he lengthened and corrected the equinus. At the end of the lengthening stage, this is how he looks. He gradually went into more and more valgus, for which we, in a second stage, 4 years down the line, we performed a double osteotomy to correct the valgus at the upper end of the tibia and to correct some of the procurvatum and valgus at the lower end to give him this kind of result on the last X-ray. And then finally, he came to us for a second hindfoot realignment procedure, which we have done. You can see on the ankle X-rays that there is again this K-bias and the opening wedge osteotomy that we have performed at the distal level combined with the proximal lengthening to give him a better alignment of the foot and ankle as well as a good amount of length. We had to be satisfied with this kind of result, and the child was doing reasonably well. He wasn't obese, so it's not too big a problem for him. And he came to us several years down the line with this kind of a picture with the increasing shortening. And he was still able to walk well on the hind foot, even though it was like a rocker bottom. So here he is in the final stage. He got much more lengthening and a correction of the valgus at the upper end and a supramalleolar osteotomy with shortening at the lower end. That helped us to correct the dramatic ankle valgus that was developing because he has no support from the fibula. And we can combine these various methods of shortening, trapezoidal wedge resection and shortening, and lengthening and gradual correction of the deformities. And this is how he is, close to more than 20 years of age. He's got some shortening. He wears a raise. He's fairly happy with his hind foot and foot function, and he's able to function rather well. And the grandparents and the parents are quite happy. Here is another example of a young child. Now, there are aspects of the fibular hemimelia that become apparent to us only as we gain in experience. This child came to me at the age of 5 years with 5 centimeters of shortening. So we promptly lengthened him because his hind foot wasn't too bad. And if you notice the X-ray on the left over here, he's got this, the fibula started migrating proximally. You can see the growth plate, which was at the level of the ankle, is now migrating proximally. If we go back to the previous X-ray, we can see a distal migration of the proximal fibula. All of this has implications in the future, as we ruefully found out. At the end of this stage of treatment, he has almost, he was a couple of millimeters longer, but unknowns to us, he started developing a mild amount of valgus at the ankle. So in the second stage, when we performed a hind foot realignment. This is how we presented at the beginning. Notice that we performed the proximal lengthening in the third X-ray from the left. And at the lower level, you can see that there are thin half pins in the lower fibula, which we have transported down by lengthening the fibula. We have also performed a hind foot realignment procedure by opening up the fusion between the talus and the calcaneum. The calcaneum, which was lying parallel to the talus, has been brought down. A tarsal tunnel release has also been performed to enable, the full correction without neurovascular deficit. At the end of the procedure, with some lengthening, you notice that we have fused the fibula and brought it to station and fixed it with these 2 screws to make sure that it does not migrate again while the fibula lengthened at the lower thirds. So this is how he did. For some reason, his mother was very antsy about removing those fibular screws, and I don't know why I gave in to the pressure. And promptly after removing those screws, the fibula started migrating slightly proximally and posteriorly as well. This is something we see, but he's done reasonably well. The valgus remained well corrected. As he grew over the years, he started developing a significant amount of valgus at the knee. This is what happens when you have a distal migration of the proximal fibula, which is why all the small nuances of lengthening, such as capturing the proximal fibula with a half pin or a wire, are so important. So we performed promptly guided growth when we saw him to help him to correct. And what I did notice, but was chary and wary of correcting, was this anterior subluxation of the proximal tibia on the femur. Now, this is a deformity. The anterior cruciate ligament laxity comes to light and comes very much to our notice as they become adolescents, because they start becoming more active and the anterior subluxation starts becoming really painful. It's a bad pivot shift because of the significant slope of the lateral tibial, joint line. So this is how he presented to us. His valgus was being corrected at the level of the knee, but due to the significant subluxation, he was beginning to have pain. So therefore, we took him up for the ACL reconstruction. This is on the table with an arthroscope. We performed a notchplasty, taking care not to damage the growth plate. And here is the guide wire that has gone above the, through the tibial physis in order to create the tunnel. Here you can see on the lateral side, we have harvested the IT band. We have, split it into two halves. We have ligamentized it. And on the left, you can see this is the position of over the top. It's been brought underneath the lateral collateral ligament and through a rent in the lateral intramuscular septum has gone over the condyle. And you can see it's being brought out through the knee joint like so, and fixed with a biotenodesis screw, which happens to remain within the physis and above the growth plate to prevent an arrest. And here he is with a much more stable knee joint and is able to, function well. His pain is reduced. And, there is a little bit of very small amount of shortening, but he does need much more rehab before he can be very comfortable. And we counsel all of these patients not to put on a lot of weight. They are so these are some of the issues: the hindfoot reconstruction, the anterior cruciate ligament reconstruction. Just wanted to show you a few more examples. This is a young lad who came to us with fibular hemimelia, small number of toes. At early lengthening in childhood gave him a decent result. Some valgus developed, as you can see. As he grew, he came and saw me a couple of years down the line with some valgus. But as he grew up into a young lad, he had a reasonably good ankle and residual shortening, from which he demanded a lengthening. And the lengthening over nails technique, which has been used very nicely by us for the last 25 plus years. This is a femur nail, a straight nail over an LRS fixator, and gave him his required 6 centimeters of lengthening to give him almost equal leg lengths, the very little amount of shortening, and very good function in the knee and reasonable function in the ankle. He is now a medical student at the prestigious KM Hospital, St. J.S. Medical College, Mumbai, which also is my alma mater. And I'd probably like to end with this very interesting example. This young lad came to us. This is a fibular hemimelia, and the significant valgus and procurvatum almost has turned his, the sole of the foot facing completely behind and even upwards towards the ceiling. And we thought about what we could do in these circumstances. And since this was done about in the year 2003, I chose to perform a shortening resection at the middle of the tibia with a wedge resection and use the Taylor's spatial frame to thereafter lengthen and gradually open up a posteriorly open wedge and a posteriorly and a lateral open wedge to turn his foot around to make it face forwards until he had a foot which was at least facing forwards. And in the second stage, we hope to perform a formal hindfoot reconstruction with his heel being brought down. So I thank you very much for your attention. This is the fibular hemimelia really is a huge spectrum of disorders. And I think all of us are learning. And as we go along and with the cooperation of the patients and understanding their requirements and their disabilities, we are able to offer the patients what may be a better quality of life and much better, control over their deformities. So I thank you very much for your attention, and I'm trying to stop the sharing.
Yes, thank you, Milind. Before we progress to the case discussion, I will request Hitesh. Do we have audience question?
Yes. The question to James, actually the question came from one of the Thomas, he asked that have the expert in their journey moved more towards the amputation and prosthetic fitting rather than reconstruction? What are your views?
What is the first part, he said? What's the first part of the question?
Whether the expert in their journey move more towards amputation and prosthetic fitting rather than reconstruction?
No, that's I wouldn't say I have moved to become more sort of ablative. No, not at all. We still individualize and choose that patient correctly. So it's still the end of, it's all about patient selection. I think whoever is asking the question, if he is going to deal with them, he has to think how well he can cope and manage some of these difficult cases, which Prof. Hosny and Milind have kindly shown. If you're capable of doing that, kindly do so. That doesn't mean that everyone has the capabilities. That's what I'm trying to say. Yeah.
Yeah,
Yes.
just quick question to all of like the 4 faculty of your caseload. In how many percentage of patient, approximately, I don't want exact number, you go for ablative procedures? James first.
I would probably say maybe 1/3.
1/3. Yeah, Milind.
None at all. None at
Okay.
all, Dhiren. Chiefly because the patients do not. If it's a short answer you want, the answer is over. But
Okay.
we have reconstructed significantly older children and young adults by a combination of shortening and wedge resection osteotomies to make the foot plantigrade, and it allows them to walk despite the fact that they have bilateral fibular hemimelia. They become more or less plantigrade, and none of them want amputation in my practice. That's
Okay, Jerry, what about you?
About 4 cases have recommended amputation because they were unreconstructable, but naturally the patient, they never wanted that and they went off elsewhere. I don't know what happened after that. Probably
Okay,
they would
and
be
yes,
living with an extension processes.
Yeah. Professor Hosny, in your practice in Egypt, how many patients accept amputation?
I don't have an answer because they refer the patients to me because they don't want amputation.
Okay.
So it's not in my scope.
Okay, right. So any patient coming to you is always like patient coming for the reconstruction.
Yes, yes.
Right. Okay.
He knows
Yeah,
that
Hitesh.
before coming.
Yeah, Hitesh, you can continue.
Another question to the limb lengthening, that how would you avoid tibia valga, because invariably with limb lengthening, many children with fibular hemimelia will go for tibia valga and procurvatum. What are the tips to avoid that?
Yeah, it's a really good question, and it can be a real bugbear. I think there are several tips. One of them would be to fix the proximal fibula and also fix the distal fibula very securely, maybe with 2 screws going from the fibula to the tibia. That's 4 cortices minimum of fixation. That's the fibula and the medial tibial cortex with 1 and 2 screws to prevent the proximal migration at the ankle and to prevent the distal migration at the knee, which can create significant disabilities. We've had papers written in the JBJS as well as the JLLR. That's the Journal of Limb Lengthening and Reconstruction, of which Professor James and Professor Hosny are both on the editorial board, the most experienced gentlemen. So this is a big feature of the cause of the procurvatum. The cause of the valgus, sorry. The cause of the procurvatum is the inadequate resection of the soft tissues and inadequate correction of the hidden procurvatum deformity, which is present in the lower end of the tibia. And frequently what needs to be done more and more, I see, is the need for a trapezoidal wedge resection to correct the deformities adequately at the level where they are present and perform lengthening at a pristine proximal level, which will, prevent this problem from happening. So more of tibial shortening in the presence of the deformities and an adequate care of the fibula and very judicious soft tissue resection of the fibular anlagen and the capsular resections at the level of the ankle and subtalar joints.
Thank you. The question to all panelists, that how do you address the knee fusion along with the fibular deficiency? Congenital absence of knee or fusion of knee?
Now I'll show you one of the cases, congenital fusion of the knee in the case presentation, which we have treated.
Okay, okay.
So I think that
Then we can't go with that. The question to Professor Hosny, yeah, how do you address the tarsal correlation with opposite side inclination of the ankle, the inclination, abnormal inclination of the ankle articular surface?
Abnormal inclination is a real problem. And I don't know, in the literature, they ignore it. They ignore the presence of abnormal inclination. And usually it's a part of the problem. You have misshapen talus. Sometimes the width of the talus, perhaps it's double the width of the lower tibia. We have too many problems. I didn't discuss it in details, but you know, they try with the classification to simplify the matters. With this angle, with this abnormal orientation, we do supramalleolar osteotomy in most of the cases, and at the same time we do lengthening of the fibula to correct the relationship between the fibula and the tibia. And in many cases, you are going to have recurrence again, and during lengthening, you have to do bifocal or trifocal osteotomy to correct the progressive valgus, which even happened in cases with arthrodese ankle. People think if they do arthrodese of the ankle, they are going to solve the problem with the deformity, which it didn't happen. We didn't do arthrodese of the ankle, but it came to us from the different parts. And in all the cases, we had a recurrence of the ankle deformity, even with arthrodese of the ankle.
Okay. One last question to all panelists: how the ball and socket ankle joint will influence the decision making? First, James.
That's quite an interesting question. I used to try to, in the past, do some spherical type of osteotomies and so on, but they do get impingement pain. So I've stopped correcting any of the ball and socket. But I will correct the foot below, depending on the position of talus. Sometimes I will do like a U if they are a functional foot and increase their submalleolar height, especially for shoe wear. So there are other tricks you can do, but trying to derotate, I think, is possibly not the right thing. So yeah, ball and socket is a better ankle actually than all the others.
Hitesh, you are mute.
Hitesh, you are muted.
Yeah, any comment from Professor Hosny? Anything?
Yes, I don't do anything for the ball and socket ankle. And I just want to tell my philosophy that don't try to be, don't try to be that's optimal with the ankle, because sometimes with trials to make it 100% normal, you are going to have stiff ankle or spontaneous fusion. And I've seen a spontaneous fusion in a fair number of cases because of multiple osteotomies, and many things were done just to have, it's exactly like anatomical ankle. Remember that any movement of the ankle is better than having totally stiff ankle or arthrodesed ankle, even if the shape of the ankle is normal. Don't try to have a normal ankle, because sometimes you have irregularity. That means the shape of the lower tibia is abnormal and the shape of the talus is abnormal, but they are articulating with each other. If you try to make it anatomical, you just stop the movements and take care. So many times, think twice before correcting the ankle, and don't think about animations, because animations take you to the world of Mickey Mouse and the things like this. But in the real world, in many cases with the fibular hemimelia, you have irregular or regular irregularity of the joint, and you have to respect the regular irregularity of the joint.
Yeah. The last question: how will you deal with the ankle dislocation with the complete the fibular hemimelia? From presentation.
Yeah. So, if I were to answer this question, there's very frequently a intra-articular deformity of the lower tibial plafond, especially in valgus, with the hind foot significantly in valgus. There is a tibio-talar fusion, and the calcaneus is lying lateral to the talus, and the calcaneus is also in dramatic amount of equinus. So if they come to us significantly early, we could start by correcting the valgus at the level of the ankle. And that's one way of doing it. The other way is shortening trapezoidal osteotomy at the supramalleolar level to ensure that the lateral inclination, which causes the subluxation of the ankle joint, is reduced and brought more or less horizontal. And I think a combination of doing the shortening resection without actually touching the ankle, and then doing the lengthening, because now I'm less afraid of shortening dramatically, in order to get the adequate correction and horizontalization of the majority of the plafond. And that's one trick that we can use to correct the laterally subluxated ankle.
Thank you, Milind. Now, I request Professor Hosny to start his case for the discussion.
Okay. That case presented to me with bilateral hemimelia. Don't know which type. You see both thighs. The patient had fractured femur, and he was treated with a cast on the left side. And this is at the age of 4.
Slides are not progressing, please.
Again.
Yeah, again the same thing. Can you go to the full screen mode, because still you are not in, exactly from there.
Is that okay?
No, not, yes.
It's not in full screen. Okay, we can see that.
Yeah.
Yeah, good that you can see that, because it's, for me, it's a full screen. I don't know what's going on.
Okay.
Can I have your opinions in this case, bilateral case?
No, this is not bilateral case. This is still a unilateral case, and we have seen this case before also.
Professor Hosny, we'd like to see the lateral view also, if it's available.
Yes, just. Okay.
Yeah.
This is the lateral view.
Yes.
Both sides. Do you have any suggestions? Milind, you are muted.
Yes. One suggestion could, Professor Hosny, one possible way to look at this could be to shorten the left, tibia, which will allow correction of the procurvatum as well as the hindfoot deformity. And since the right tibia is going to present a significant challenge and a significant leg length discrepancy, that would be one way to go. But it seems as though your right femur has overgrown and compensated. So I think we can treat each limb according to its own merit and give at least the left lower limb a very good, as best as possible, a plantigrade foot in order to have one good limb to stand and walk on. And on the right side, at much later stage, we can intervene if we see what's how it is progressing with growth.
Yeah. Good suggestion. Yes. Do you have other James, you.
I think for you, you're going to, like Milind says, it's you're going to individualize your treatment to this child. I'm sure there is no option for you in Egypt for ablation. So if they were here in the UK, if I tell them the number of surgeries they will need, probably they'll opt for ablative surgery on the right side, and then you reconstruct to the left. It's very rare I try to ablate both. Extremely rare, or maybe I've never done. I try to reconstruct the better limb, and then, yeah. So I think that's what you'll have to do. I think you will still probably, in your situation, will have to have a strategy of whether you're correcting the foot first, bring it up on the right side, and then with shortening procedure, and then later on go for lengthening. I suppose that will be your strategy. On the left also, you'll have to think about the left foot as well, isn't it?
Mhm.
Yeah. So that's what I would do. I think about classifications. Unfortunately, that's what I said in my talk. Classifications, are okay. Maybe if they're isolated. Most of these conditions we are seeing, they have got many things going on, and many are combined deficiency and multi-birth defects. So it's very difficult to classify them. I think your strategy of treatment has to be individualized to each, and according to me, to each country differently, I would think.
Yeah, I agree with James. I think what's happening on the right side is that probably it's a combination of tibial hemimelia as well as fibular hemimelia. And this is what looks like a delta tibia, what's described as a delta tibia with an absence of the fibula. And, it's a variant with a combination of both features. The tibia itself is poorly formed, and we're going to have a very creative and interesting challenge ahead to how best we could reconstruct this.
Yeah.
So interestingly, we had a similar kind of delta tibia in a child whose father, it was a syndromic condition, I think from memory is Robinov, I think. And the father had bilateral disarticulations of his knee, but he used to drive a heavy goods vehicle in the UK. But he did not want his daughter to have an amputation. Interesting. So we reconstructed her. It went very well. She is in university now. Yeah. So this is what, even though probably she was a candidate for disarticulation, we still reconstructed. So it's not that, at the end of the day, in the UK at least, the most of the decision is made for us by the families. We just tell them what is available and how many things we can do.
It's everywhere. It's everywhere. So if we look to the left side, it's a fractured femur, and we were expecting to have over lengthening with growth. It's expected. So we were not bothered by the left femur or something. We discussed things with the families, and the families were, we're having a problem with the right leg because the shape of the right leg for them was awkward if you compare it to the left leg. And for me, I thought about starting with the right side, because if you don't have something on the right side, you don't have to move to the left side. So we started with the right side. And this 2013, from 8 years ago, this was the first operation. We did corticotomy and lengthening, just corticotomy and lengthening. Because we had a very small piece of bone, and we want to see we didn't want to do an MRI or something like this, or something to see, are we going to have something like a knee and something like an ankle, or we don't have to? So we did just corticotomy and lengthening of this piece of bone, and also we fixed the femur in a trial to have something like knee or ankle or something like this. Anyhow, we ended up with this picture. It looks like we have a proximal physis, it's good, and we have a distal physis too. We didn't see that before. We don't think that we have a physis, upper physis and lower physis. We didn't think so. So we had both, but at the same time, we have this
inflection,
posterior, and leg length discrepancy. This was 2014, and we waited 2000 to see the growth of this piece of bone. Then, again, we did corticotomy. and more lengthening. At the same time, there was severe valgus deformity of the left side. See, we did guided growth on the left side. Then we removed the frame. Again, it's getting better. We started to have physeal growth. We started to have growth of the tibia. We don't know. If we did corticotomy and lengthening, have we stimulated the growth or we inhibited it? We don't know. But it's growing, as you see here, with this shape of the ankle. And with more growth. Look to the picture here, and leg length inequality. Remember the small piece of bone, but there, and look to the difference. Then we removed the knee 8 plate and we put it in the ankle to correct the valgus ankle on the left side. It's getting better. But you see the shape of the physis up and low. Still, there is a subluxed knee. This is the last operation. We moved the 8 plate from the ankle and we applied 8 plate for the upper tibia because we have recurrence of the deformity. We did tibia lengthening and did derotation because the foot was rotated about 50 degrees. There was internal rotation about 50 degrees, and we did rotation, X-rotation, and the gradual reduction of the knee. We did gradual reduction of the knee. Everything was okay, but we removed the frame, but we had a fractured femur. We don't know why. So we applied the frame again to the femur. And this is the fractured femur. And this is the 8 plate we applied for the upper tibia. And we removed the frame. You see the knee in the lateral positions. The patient was waiting for anterior cruciate limb reconstruction. And we told him that after this operation, because we need to do something for the anterior cruciate. But we don't know. Fortunately enough, we had this picture and stability. We don't know why we had this stability or why this time we had this reduction. Till now, we don't understand. So this is the picture before. Remember, this piece of bone, and now. And this is the clinical picture. And we canceled the anterior cruciate reconstruction. We don't know why he was quite unstable. Why now he's stable? We don't know. It's always in congenital problems. There is a dark side, we don't know. And I like to say that we discover things bit by bit. So I wonder why people talk on the internet with this confidence about their great experience with congenital deformities, which I don't have. We've been treating hundreds and hundreds. And with each case, we have new secrets, which we didn't discover until now. You know, we are learning from the cases. And I've learned all those years not to have sharp decisions. And when you talk to the patient, just give him the possibilities. And don't give him sharp decisions. And just, I hope This was a good case.
Amazing.
This is the new road. Thank you.
Amazing.
So you're muted.
Yeah, I think the message what Professor Hosny said exactly echoed with what Milind said in his talk, that the knowledge of us or the medical community about this condition is work in progress. And with time, we are learning new things, and a lot of things still we don't know. So, which is exactly we saw in this case. So with that, now we go to the second case, and I think that will be the last case. Cherry, can you go through your case?
Yes, sir. Yeah. Somebody was asking about congenital knee fusion, and that is exactly what I'm going to show with the knee Fibular Hemimelia. Now, this is a 9-year-old girl. She had diagnosed as congenital knee flexion contracture with the left lower limb on the right side and left lower limb also deformity. The knee range of motion on the right side was nil, and on the left side was full range. Now, the foot had absent lateral raise and bilateral fibular hemimelia. Now, this is the picture. Any comments?
Was a patella present on the right side, Cherry?
I really couldn't appreciate anything, Milind, because the knee was solidly fused. Now, this is the feet, 3 toes in each.
Sorry, the knee is a complete synostosis, yeah? Yeah.
Yeah.
Okay.
Now, this is it's almost maybe about a 120-degree deformity with fusion of the knee. You couldn't get an AP view of the knee, understandably.
The upper limbs were normal? The upper limbs were normal?
Yeah, the upper limbs were normal, yes.
You can just straighten the knee by making an osteotomy and gradual correction.
Yeah, we'll come to that. Now, the left upper limb also, the left limb also had the same problem, fibular hemimelia, but mobile knee joint. Now, this is how she came walking to my OPD at the age of 9 years. The parents had approached some of the doctors and they said the amputation is the only option. So this was the way she was walking, very active child, very intelligent girl also. So the diagnosis was bilateral postaxial deficiency with congenital fusion of the knee. Now, what are our options here? One is what Professor Hosny said, is straightening out. Any other options?
Yeah, I mean, it's fortunate that that I think to reconstruct a knee with partially absent articular surfaces or partially absent ligaments and lengthen becomes so much more difficult. So our task is a little easier because of the knee fusion here.
Yeah.
And it would give her a good sound limb, straight limb after you've done with the right side. I would presume that we could start with the right side. And as Professor Hosny said, we could, if you do the supracondylar osteotomy, then it'll simulate this very tiny amount of knee flexion that's needed after the fusion. So lengthen and correct the flexion with a supracondylar level osteotomy and let the distal fragment remain slightly anteriorly translated and lengthen quite a lot, because it's a broad bone, so we can lengthen quite a lot to the desired extent, I suppose.
Okay, we made a plan and we decided on 2 osteotomies to make things a little more faster.
Okay.
You can do with 1 osteotomy, I agree, but and one of my colleagues suggested 3 osteotomies, but I think that 3 was taking things a little too far. So this is the planning we did. Made it on the tracing paper and cut the film. And this is the frame we made. It's a little complicated frame because we couldn't fix the distraction rods on the concave side. So we had to fix all the distraction rods on the convex side. So the thigh part and the leg part. Leg part at the ring and ring. So this is how the frame was fitted. The proximal osteotomy and the distal osteotomy. They made it 2 coras. Yeah, these are the. Any comments, Milind? You're muted.
Yeah, it's a lovely pre-constructed frame, and that's a treat to watch, and that's really elegant. And you've solved the problem of not having enough space posteriorly to be able to. Looks very nice indeed.
No, we just decided to, yes. We decided to initially do the lengthening, then do the deformity correction. So that's what we did. Get lengthened so that the bones don't impact against each other. So we lengthened before doing the deformity correction. That's a lengthening and the deformity correction. That's slowly the deformity correction. That's a deformity that is corrected. That's the end result. I mean, before the correction. The frames are all straight. Yes, Dr. Hosny, any comments?
Yes, it's the people suggested 3 osteotomies to correct the problem.
Yeah.
And I think it was very wise to do only 2.
Yeah.
Because if you want to have a stable frame,
yeah,
remember that we created the mechanical axis. You know, this is our theory, no more. So if you want to correct the deformity, you have to think about the stability of the frame. So if you do a 3 osteotomies, you are going to have unstable frame.
Exactly.
So it was very wise of you to do the double osteotomy.
Yeah.
And I always warn the people, because sometimes if you have, sometimes you have half a circle deformity. And if you want to correct it 100% and correct the mechanical axis, you have to do 4 osteotomies, not 3 osteotomies.
Yeah.
So it's not the matter of the number of osteotomies, just the stability is quite important. Yeah. So I agree with you entirely that you did 2 osteotomies and this was the right thing to do.
Yeah. So that's the end correction. The bone doesn't look perfectly straight, but anyway, clinically that's okay.
I think you've done a good job, Cherry.
Yeah. This is a pre and post-op gait.
Wonderful.
Yes, look to the clinical picture. Don't think about the mechanical axis.
Yeah.
It's not a perfect mechanical axis, but it doesn't make any sense to think about having a perfect mechanical axis. Look to the clinical picture.
Yeah.
I think the main thing is you made someone really happy.
Yeah, they're very happy about it. So it just needs a lot of planning, that's all. Anticipate problems. And of course, like we all said, gradual correction offers the best solution. And I don't think any of the apparatus really fits the bill except the Ilizaro apparatus. Milind, can we do it with the TSF?
Oh yeah, definitely. We can use an arc which is open posteriorly.
Yeah.
And then probably you would have been forced to be satisfied with performing only a single osteotomy.
Yeah, that's
and
what I
it wouldn't
asked.
have been as dramatic. But yeah, I mean, it just makes 2 arcs, both open posteriorly, and just probably at the broadest part of the knee joint where it's fused, just the corticotomy there. And you could do lengthening. Yes, the TSF will make your job easier because I'm sure you and your team had to work hard in the post-op phase to make the montage changes, which becomes a little easier.
Yeah, with the TSF, I do agree. Yeah. But I believe the TSF, after about 45 degrees, the calculations go a little haywire.
You can, sorry, carry on, Milind.
No, you're right. It's not necessarily haywire. It's not necessarily haywire. You always have the option of the total residual correction because there are issues with the TSF. For example, if the rings are too close to each other and the struts are small and are greatly angled. That's a well-known thing that was published in the JLLR, and not necessarily haywire. The beauty is having the total residual correction in which you can add, because even our Chandrayaan or any NASA spaceship going to the moon or any other place in space never takes the intended trajectory, and they're always making corrections with their computers in Houston. So we can do the same.
Okay, I think we are already crossed our time. So now I request Dr. Hitesh to pass a vote of thanks. Thank you once again, everyone. Over to you, Hitesh.
Thank you, Dhiren bhai. On the behalf of POSI, I thank all the faculties, Dr. James Fernandes from UK, Professor Gamal, Hosny, Dr. Chaudhary Kovoor, and Dr. Milind Chaudhary to sharing their word of wisdom on the topic, complex topic, Fibular Hemimelia. I also thanks Ashok and Neeraj for providing the platform for the OrthoTV for arranging the webinar. And this is the 47th webinar on the POSI. I also thanks all the POSI delegates and all the audience for the listening and sparing time to listen the topic 1.5 hours to part from their family and joining at the late night. It's time up, so I will conclude it here. Thank you very much, one and all.
Thank you.
Thank you.
Good night.
Thank you, everyone.
Good night.
Thanks.
Bye,
Thank
Gamal.
you. Bye. Bye, James.
Yeah.
Bye.
Thank you.
Good night.
Thanks very much. Good night.
Bye. Good night.
Good night.
Good night. Good night. Yeah.